good to have all of you here today. And as always, we want to say a great big thank you to the Oliver Center. How many of you have ever looked on the website at former Lunch Bunch videotapes? A couple of you have?
So most people can see the video or the presentation. I've got a lot of pictures based on some of my experiences in the cancer pain world and also the chronic non-malignant or chronic pain world as well, and just kind of a brief introduction to some of the interventions and some of the things that we do that is hopefully changing, and people are becoming more aggressive towards the interventions and the treatment of pain. So, and a lot of these slides I use for some of my educational talks to some of my residents and fellows too, so bear with me. So how many people have been to the hospital and somebody's asked you what your pain score is? What's your pain score? And when anybody's ever had any pain, does it just come up to the brain and say, that's a 9? Or that's a 10, you know? And so I kind of always get annoyed with the pain score, and we'll talk a little bit more about that in a second, because if it hurts, it just hurts, and the number is kind of hard. So how many people would think that that is a 10 out of 10 pain? Probably most people, right? So what if I said that this patient, boom, nail gun, right through the shoe, goes into the emergency room, 10 out of 10 pain, give me Dilaudid, give me this, and they give him IV, and they're pushing the meds, and he's still 10 out of 10 pain, writhing around. And then they go to take a shoe off, and they realize he actually missed his entire foot, and it went through the web space. So was he in 10 out of 10 pain? And so the question is, I use that to kind of define what pain is. And so pain by the IASP definition, it's an unpleasant sensory. Everybody would say that that's unpleasant. And it's an unpleasant sensation. And it's an emotional experience. And it's associated with actual or potential tissue damage, or described in terms of such damage. So that patient was in 10 out of 10 pain despite the fact that they missed any sort of physical structure in their pain. So that's just a picture to illustrate that pain's a little bit more complex than we originally one may originally think. But we'll talk a little bit more about that in a bit. So the objectives of this talk, again, stop me if you have any questions along the way. I'm going to talk briefly about the sort of opioid prescribing pendulum that we're going through over the last 30 years and a bunch of law changes that have happened in October of this past year, with the increased scheduling of different opioid medications that have made it harder to get these medications, and why the reason for that is. Hopefully by the end of this talk you realize that pain is complex. If you don't remember anything else, just remember the guy that shot his foot and was in 10 out of 10 pain and realized that he missed his foot about 20 minutes later. We're going to talk a little bit about the multimodal approach to pain management, and specifically my approach, but specifically the interventions are what we'll talk about. I'm going to briefly hit on cancer pain, or spend about 5 to 10 minutes on cancer pain, because how many people in here have either had cancer or known somebody with cancer? And that should be almost 100%, right? And often it's not the cancer, it's the potential pain associated with cancer that people fear more than cancer of itself. In fact, I've had some patients quit their cancer treatment because of the pain sequelae from the cancer treatment, which is interesting. So we'll hit on that. And then we'll talk about chronic non-malignant pain, specifically focusing on some of the interventions. Some of the bread and butter interventions that we talk about: epidural steroid injections, facet joint injections, large joint injections, burning of nerves, or radiofrequency thermocoagulation of various nerves that we can do to help patients manage their pain. And then we'll talk about some of the newer, sort of more aggressive things, which is intrathecal drug delivery, which is basically drug delivery in the spinal column itself, both for cancer pain and for chronic non-malignant pain. We'll touch briefly on vertebroplasty, kyphoplasty for vertebral compression fractures, whether it's cancer-related or non-cancer-related. And then also at the bottom, the topic I think is very sexy, if you want to use that term, is the spinal cord stimulation, which is a non-pharmacologic approach to the treatment of pain, and we'll touch on that in a bit. So the opioid prescribing pendulum. So there's the poppy seed, and let's just take for 5 minutes kind of the journey over the last 30 years of kind of where we're at. And then in the 1980s, there's a published paper in the New England Journal, Addiction is Rare in Patients Treated with Narcotics, and this is a small study, but N equals 38, and they basically said patients don't get addicted if you give them some sort of chronic pain opioid medication, not necessarily all medication, but opioid medication. So then the pendulum started swinging, and in the 1990s, the medical board started easing restrictions on opioid prescribing habits, and specifically, no disciplinary action will be taken against a practitioner based solely on the quantity and/or frequency of opioids prescribed. So that's the 1990s. In 2000, Joint Commission, or JCO as it's fondly known around all hospitals, starts implementing it's a right for pain relief. So anyway, in 2000, Joint Commission comes out with the right to pain relief. And so aggressive marketing campaigns started stressing that we're under-treating pain. And in the 1990s, 2000, we came up with this 5th vital sign. So not only do you get your vitals, but now everybody asks you this pain score. What's your number? What's your number? What's your number? Which I'll have a whole nother conversation about how annoying that can be, especially when you're in pain, if somebody keeps waking you up to ask you what your number is. But anyway, it is what it is. And so the 5th vital sign comes in. And so as a result, over the last 30 years, it was very effective in the amount of opioid prescriptions. They dramatically went up, and in fact, over the past 10 years, per capita sales for opioid analgesics in the United States increased by 600%. So what's the problem with that? Now we have an opioid epidemic in the United States, and worldwide, everybody's heard of Norco or Vicodin or Lorcet. The world's Norco, the United States prescribes 99% of the world's Norco, which is interesting. Yes, ma'am.
I have a question.
Yes, ma'am.
1980 publication. Like, what was the duration or the length of the treatment on the opioids?
You know, I don't know. I don't remember because it was an old study, but it was a very small study, 38 patients, and very small. And I don't particularly remember the duration of treatment, but that was just one example of some of the studies that kind of shifted that thinking. But at any rate, so this opioid epidemic, this is kind of a striking feature because when you put a picture on it, it starts to really hit home. So in 2009, there were 15,000 opioid overdose-related deaths. So that's almost a 9/11 every other month, which 9/11, you can see what that's done over the last 15 years. If this started to become a more visual thing, this is what's starting to drive the change. So I'm from Ohio State, and they won the national championship, so I like to put a lot of pictures up of Ohio State. But at any rate, it's hard to imagine what that number means. So at Ohio State, their stadium holds about 100,000 people, about 110,000 people. I think Reliant is in the 80,000s. But this is 100,000 people on a football Saturday in Columbus, Ohio. So over 6 years, that's how many people we're killing based on our opioid prescription habits, just on overdose. In 13 years, and the reason why I use the number 13 is when I lecture my residents and fellows, that's the time it takes after 4 years of undergrad, 4 years of medical school, 4 years of residency, and then a year of fellowship training. When you become a pain doc, for that time, you've killed now 200,000 plus patients just on opioids. And it's not just death. For each death of opioid overdose death, there's 1,000 non-medical uses of marijuana, or not of marijuana, we were talking about marijuana, but of opioids. There's 1,000 cases of abuse and dependence, and there's 10 to 20 abuse admissions. So we've created a problem, and now we need to try and figure out how to fix it. And the question is, where are they getting all these opioids from? So this is just based on a survey, and forget all the details, but so they surveyed everybody of where they're getting the medication. The vast majority, they're getting it free from a friend or a relative, and the vast majority of those are getting it from one doctor. So that means they're getting it from me. So now you can see why we're creating a problem and why we need to be cautious about how we treat that. So the recent literature trend is that there's no long-term studies for long-term effectiveness of chronic opioid pain medication for the relief of chronic non-malignant pain. It's very hard to find. I would challenge anybody to find one study to show me. There's this myth of that there's no upper dose limit of opioids. That used to be trend of, you get tolerance, so you just increase the dose, 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 and then by the end of 10 years, you're on an elephant's dose of pain medication, and there's a lot of problems that come along with that. Addiction is much higher than this 1% that was originally quoted kind of in the 80s. But it's not just addiction issues, it's physical and psychological dependence that can potentially become a problem. So that's just to kind of illustrate the point that pain is very complex, and that when people think of a pain doctor, they think, oh, well, you're going to go to him because he's going to give you Vicodin. And that's not what we do, and that's not what I do. Opioids are one tool in the medication category, but there's several other things. So we'll talk about that in a second. But pain, once you get that nail, if it actually went through a bone or the skin, you get this transduction, transmission. The signal goes from the periphery up the spinal cord, and then there's a lot of magic that happens at the spinal cord that we don't really understand quite yet. But sometimes that pain signal is amplified, and sometimes that pain signal is attenuated. And think of the soldiers fighting wars over in the Middle East that get shot out on a camp and they don't realize it until they come back, and then, by the way, they've got a couple holes in their body and they didn't even realize it, right? So why did that happen, yet the guy that shot himself with the nail gun was in 10 out of 10 pain when he completely missed? A lot of that happens at the spinal cord level, and that's what we don't quite understand. So when you come to me in the pain clinic, we use a multimodal approach. It's medications, and I didn't say opioids on there, although opioids are a very powerful tool and used appropriately and monitored, very effective for the treatment of chronic non-malignant pain and chronic malignant or cancer pain. Interventions, which is the focus of this talk, but physical therapy, occupational therapy, art therapy, complementary alternative therapy, I kind of bunched that all in one category, and then psychological support. If anybody's had a stubbed toe or something for a period of 5 minutes, you can imagine what that would feel like if you had that all the time, 100% of the time. And the best, instead of the number score for pain, the best adjective that somebody uses is it's exhausting. When you can't do anything else but think about why you're hurting, it's exhausting, and that's the best descriptor. So at any rate, this talk is going to kind of shift to the focus of the interventions that we do in the first kind of 5 to 10 minutes on the cancer pain interventions, and I'll show you some pretty unbelievable pictures to show you some potential opportunities if you or one of your loved ones ever unfortunately comes across something like this. And then we'll shift into the chronic non-malignant approaches with an emphasis on the intrathecal drug delivery and also the neuromodulation procedures. And again, this is just one prong of that four-pronged approach that we use. So don't think that everybody that comes in, this is the only thing that we do, but this is one thing that we do. And so just wanted to get that out there. So, okay, so cancer pain. In the cancer pain world, well, first of all, cancer pain patients also have chronic non-malignant pain as well. If you have a chronic back pain problem, you're just as susceptible to everybody else at getting a cancer. So just because you have cancer pain doesn't mean you can't have the other bread and butter pain, for lack of a better term. But for cancer pain specifically, we'll talk about some diagnostic and neurolytic or ablative blocks that we can do. I talk to patients about a breaker box, kind of turning a nerve off, and some ways that we can do that. There's local anesthetic and steroid or potent anti-inflammatory medications we give. And then these ablative blocks, we can use actually an alcohol or a phenol concoction that actually is neurodestructive to different nerves. This RFTC stands for radiofrequency thermocoagulation, is also a destructive electric tool that we can use to destroy painful nerves. Intrathecal drug delivery, again, delivery of medication via the spinal column. And I'm going to touch briefly on chordotomy, which is not many people know about here, but we'll touch briefly about that as well. So sarcoma. You don't have to be a radiologist to figure out that this picture doesn't look right. Sarcoma is a very nasty cancer. You can see this large tumor in the, this is actually the right humerus, and this is the chest wall. This is the spine coming out. Large tumor, and just underneath that is skin, subcutaneous tissues, and also the brachial plexus, which is the feeder of nerves that feeds your right upper extremity. So this patient presents with crushing, dull, aching, sharp pain, and then also what we call neuropathic radiating pain because of the involvement of those nerves. It's just like electricity. When you fray those nerves, they start acting funny. And that's what this patient's present with, and an impressive growth of that tumor. Here's a sarcoma of the left lower extremity. Again, you can see it on a PET scan here, and then you can see it lighting up. The stuff that's lighting up is bad. Here's a sarcoma that's again involving the left shoulder and also into the left scapular region and involvement in all those nerves. This is a painful, nasty cancer, and these patients are desperate for pain relief. Again, they fear the pain more than they fear the cancer or the treatment. Potential blocks for these patients, you can do upper or lower extremity peripheral nerve injections with local anesthetic or steroid that potentially decreases some of the pain response. If that works, you can do repeated injections. You can also consider doing ablative therapies or neurolytic injections. But you're kind of tied here in that you can't destroy nerves if you want function of those nerves. If somebody has a nasty lower extremity tumor that's already invaded or already destroyed that nerve from a functional standpoint, you can actually go in there and ablate that nerve for a component of relief. But this isn't something that you would use in the bread and butter pain world. Destruction of a motor nerve, because you need those motor nerves to walk and to function. But something that is a blessing for some of these patients. And so that loss of function consideration needs to be discussed with the patient. Anybody know who that is? Anyone? Anybody know who it is now? So that was after 2 years. And what did he die of? Pancreatic cancer. So pancreatic cancer, Dr. Ryle and the team here of surgeons deals with pancreatic cancer from a surgical standpoint. Pancreatic cancer is a very nasty cancer. Hopefully, it's caught early and is treatment, but often it ends in a tragic result. And again, more than the cancer is the pain that a lot of patients talk about and they fear. And this is something that we can actually intervene in and actually help these patients. And some of my best patients are some of my pancreatic cancer patients that I've had the privilege of treating. So at any rate, pancreatic cancer, this is a cross-section of the abdominal wall. Pancreas kind of lives right in your internal inside of your belly. And these patients present typically with pain that's in the epigastric region, radiating to the back, and it hurts. And it also grows and metastasizes, and they have unbelievable abdominal pain. Fortunately, there's some specific procedures that we can do with this called a splanchnic neurolytic block, or also you might hear people talk about a celiac plexus block. And there's this cluster of nerves that lives just anterior, or just in front of the big large vessel that runs from the top to the bottom, the aorta. Most people can name that one. And that is where we're going at to try and, a lot of the feeders from the pain nerves in the belly come through this kind of gateway. And if we can block that nerve and turn it off like a breaker box, we can get a significant component of pain relief. Not 100%, because this starts to affect other nerves, but these patients typically do pretty well. Whether it's called a splanchnic or a celiac depends on if you put the needle in front of the aorta or behind the aorta. This isn't a talk about techniques, but it's just an introduction into kind of what we do. Significant pain reduction, and also these patients are usually on an opioid component that causes some side effects. This also helps actually loosen up stool as well. That's one of the side effects that's actually coveted in some of these patients. But at any rate, again, my pancreatic cancer patients are some of my favorite patients that I've been able to help. Yes, ma'am?
You're blocking that nerve. Is it still going to function?
So what we're trying to block is the visceral afferent traffic. So afferent meaning the sensation, the track of neurologic information going to the brain. In doing so, we will get a component of the efferent, or the traffic that's going out. Now, this is feeding the internal abdominal organs. So this isn't a nerve that anybody's aware of or can actually use right now. It's one of these visceral sensations that's a part of the autonomic nervous system that we can't control anyway. A component of it is turned off for a period of time. It comes back, and you can actually repeat that injection, but there's no adverse reaction as far as function or malnutrition or anything from that, the pancreatic cancer more than anything else, but this is strictly for our pain relief, even though it does have the side effects of it. Yes, ma'am. That block can also be used for colon cancer, any intra-abdominal cancer. So you think of liver, you think of spleen, you think of colon, you think of the small intestines. The celiac plexus or splanchnic block is something that we can use. The visceral blocks that we use, the stellate ganglion is up in the neck. That's not one that we can really turn off or ablate, but it's one that we can do diagnostic tests for, and use it for something called CRPS, or complex regional pain syndrome. Again, that's a whole nother 3-hour lecture outside the realm of this talk, but again, there's stellate ganglion block, celiac plexus or splanchnic neurolytic block, superior hypogastric plexus neurolytic block. Again, this is more for the pelvic cancer, so you have the upper abdominal and the pelvic cancers, and the ganglion impar, again, pelvic and perineal cancers. So again, these are neurolytic blocks that are very helpful in one of the prongs of the 4-pronged approach to all of our patients with pain. But you get these other cancers. This is anaplastic thyroid. This is a cross-section up in the neck. Here's a coronal section, kind of a front up and down section. You have this nasty large mass here. You get metastatic disease, specifically breast, prostate, lung, kidney, thyroid cancer. And what do you do with this? There's not a specific nerve you can turn off with this. Metastatic breast cancer, 1 in 8 women, right? Somebody in this room has probably been affected with that. 1 in 8 women, if it has metastatic disease, there's again not one nerve that you can easily go in and turn off. So when we get things like this, we start to think of intrathecal drug delivery. And this is also something that we can use in the chronic non-cancer pain world as well. But it turns out that the opioids, which we talk about opioids, work via opioid receptors, which this is a cross-section of your spinal cord, and they live in this rex lamina 2 or substantia gelatinosa, or at least a good percentage of them. So if you have to take a pill by mouth, you have to take a pill by mouth. It goes through the esophagus, into the tummy, into the gut. It's processed, spit into the liver, up into the heart, pumped out to the bloodstream, and then eventually gets to the spine. You can imagine that for all that to happen, you start to lose the pack for your punch each time it goes through one of these processes, right? Instead, you can put a catheter that sits right here and starts to infuse the medication along the spine and goes right to the source. By doing that, you get less potential side effects and you can get more bang for your buck, so to speak, for lack of a better term, with this intrathecal drug delivery. For these patients, if I can get them early, this is what I like to do. And again, it started targeted drug delivery, targeted not necessarily at a specific nerve, but where the medication works, right? And just a brief thing, this intrathecal drug delivery, it's a hockey puck basically, and there's different sizes of hockey puck, but it's usually implanted underneath the belly, and a catheter is kind of sutured or sewn in the back. People have been injecting in the spine since the 1800s, but specifically used for cancer pain in the 1970s, and this has really been modified and changing over the last 10 to 20 years as well, and becoming more and more common. So you might hear of people having a pain pump. Just because it's a pain pump doesn't mean that opioid is the only thing that can be used. There can be opioids, there can be local anesthetics, there can be something called ziconotide or Prialt. People call it Prialt, but it was marketed as actually Prialt, which was the primary alternative to morphine. So kind of fun branding names for all these drug companies. But that's actually a snail toxin that's used that's actually a nerve pain medication along the spinal column. And the other FDA-approved one is baclofen, or an anti-spasmodic agent that's used in the mostly in like the cerebral palsy population or spinal cord injury population. But at any rate, this is a Medtronic. There's a couple of different companies. Medtronic is one that has most of the market now. But the implant process, you generally go through a psychological evaluation, although it's not required for cancer pain. And then there's a trial period where we take you into the operating room. You sit on your belly like this. We use a little camera. We identify the bones and the structures that we're looking at, and then we put a needle into the intrathecal space. So there's the epidural space, and again, without going through too much anatomy, epidural space and then intrathecal space. It's just one space further, which increases your potency. And then you give some medication, and you either admit them or follow them depending on the dose that you gave and see how they respond. If they respond well, then you go to a surgical implant, which basically involves the same thing, except you make a little incision, you drop a little catheter, you put it along the spine, and then you tunnel this catheter from the back to the belly. You implant the little hockey puck, and that is just a reservoir of medication that infuses medication at a constant rate. And then the interesting thing in the last several years, you might see or hear patients have what they call a PTM, or patient therapy manager, which is basically, has anybody ever been in the hospital, had surgery, and had the little button that they get pain medicine? They call that a PCA. Well, this is basically the PCA of intrathecal medication. So you can hit this button, and it communicates with your pump remotely, and it gives you a little boost of medication in your spinal column, where all those pain receptors are, to decrease pain, right? That goes kind of globally. So PTM is kind of and not a lot of even nurses or physicians know about this. So they come to the hospital and they're like, what is this little button? And it's something that both physicians and population needs to know about, because you need to figure out what's in this pump, right? Intrathecal therapy is an option. Some things like lung cancer, where you've done intrathecal therapy, and this is a couple of my patients, done intrathecal therapy, done everything that you can, and they still have an intractable lower extremity, upper extremity, trunk wall pain. I just want to briefly introduce cordotomy. Dr. Ashwin Viswanathan is up at MD Anderson. He's a neurosurgeon up there, but they actually do a lesion in the actual spinal cord itself. This is for intractable, big time cancer pain, refractory to a lot of different things, where we actually, or not we, but he, I don't do this procedure, but he does, we actually interrupt the pain tract in the actual spinal cord, and you make a lesion there to interrupt that process. And so here's just a couple pictures. If you kind of look through here, this is just a scout image on a CT, and then this, you're going to follow this little white line as it's going in, and this is the actual spinal cord here. And as he goes in here, you can see this advancing, 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 and boom, there's the needle in the spinal cord right at the organization where that specific nerve root track is for pain. And then he makes a lesion there, and you get good potential results for that specific patient. That's not a non-malignant, bread and butter procedure, but that's something that these patients that are desperate for some sort of relief can get. Okay, so shifting, kind of talk about kind of the halfway point, and we'll kind of switch gears. We'll forget about cancer for a second, but remember that all cancer patients are just as susceptible to non-cancer pain. So all of this stuff applies as well. So when people think about chronic non-malignant pain, what are some of the procedures you guys think of? Have you guys heard of epidural steroid injections? People come in, they get a series of injections. Has anybody heard about burning nerves in the back or burning nerves in the spine? Has anybody heard about that? Injections in the head, injections in the periphery. So we do a lot of stuff with needles. We do some surgery, but usually our emphasis is on targeted delivery, whether that's by medication, trying to get a specific medication that's designed to go specifically where we think the pain nerves go, or by using a needle to either go at a nerve or a joint to deposit medication locally. Again, the problem, just like intrathecal therapy, the problem with taking a large dose of pills or medications, which is kind of Western medicine, right, is that it has to go through that whole GI tract and then spit into the liver and then dropped into the bloodstream to then start to work, right? And that they call that first pass metabolism. So we like to deliver stuff locally, and if it's a nerve that's misbehaving, we like to turn it off or calm it down. If it's a fracture that we can fix, we like to fix it. If it's none of those that we can do, we like to modulate it, and that's what we'll talk about, this spinal cord stimulation. Has anybody heard about spinal cord stimulation in here, or know anybody that's had that done? Okay, so spinal cord stimulation, we'll talk about that in a second. And then intrathecal drug delivery, same thing that we use in our cancer pain patient, except now the trend is, and there's only a few that are doing it actually in this region, and Dr. Wilkes in our department's publishing some stuff on this. Dr. Garcia, a private practice group that's affiliated with our group, has a lot of pump patients, non-chronic or non-cancer pain patients, on what we call microdosing, or a fraction of the dosing of intrathecal delivery of medication. And we'll talk about that in a second on what that means. But these are some of the things that we do. So I'll just show you a couple of pictures that hopefully makes this make sense. So you gotta know your anatomy a little bit, right? So once we decided we wanted to go from all fours up onto the back, the pain clinic was created, right? Whoever decided to stand up and walk on all twos put us in business. But at any rate, this is kind of a cross-section of your back. Spine pain is probably the most frequent pain complaint that we get. And what percentage of patients or people in here have had some sort of spine pain before? Anybody? Anybody? Yes, it's basically 100%, right? I myself have actually had 2 laminectomies, so it's like I'm a hair club guy and I'm the patient of the president or whatever it is. So, I can speak to this, and I can also speak to the patient that was incredible neuropathic pain and lost function in the leg. I understand what that means, and I don't wish that upon anybody. But at any rate, you have to understand this a little bit. So we think of back pain, and people generally think of discs, right? That's kind of, everybody knows, oh, I blew a disc. But there's actually a lot more to the back than just discs. You have the intervertebral bodies, which is the bone, and then the disc that people talk about is kind of the jelly donut that lives in between the bone. And it's called a jelly donut because it's got an outside layer of what we call the annulus fibrosus, or a really tough skin. And then on the inside, it literally has a little jelly donut inside filling, which is called the nucleus pulposus. And sometimes that can protrude back, herniate back. You can actually break off and have a piece of a sequestered fragment. And there's different terminology, and when you read an MRI report, it's got all these words, and you're thinking, oh my God, am I dying? What's happening to my back? What percentage do you think, let's just assume everybody in here had no pain complaints, which I would doubt. I would bet that somebody in here has some sort of pain just sitting here talking to me. But what percentage of the folks in here do you think, if I did an MRI, if you had no symptoms, would have some sort of abnormality on their back? 100%. So it's the vast majority. It's hard to say 100 in anything, but it's the vast majority. And so what does that mean? So sometimes patients come in and they say, oh my God, doc, look at this film. It says that I've got disc desiccation at L5-S1. I am dying. And I say, a lot of patients have it, and you don't treat the film, you treat the patient. So it depends on where these discs are causing problems, or these ligaments are causing problems. The anterior longitudinal ligament, posterior longitudinal ligament, ligamentum flavum, the interspinous ligament. There's all kinds of these ligaments that are just hanging out there. And the more wear and tear that we have, I always tell patients, our heart has a finite amount of beats, right? Nobody's beat Father Time, at least that I know of, maybe one guy, right, 2,000 years ago. But aside from that, nobody beats Father Time, right? So the heart has a finite amount of beats. The back has a finite amount of twists, turns, and bends. There's a reason why there's not 60-year-olds playing for the Texans, right? Because the back gives way after a while, right? Just like all of our joints do. And so you can have all this arthritic buildup, ligaments that get hypertrophied or fat and thickened. And if they happen to be in the right space, they can cause pain in and of themselves, or they can start to impinge on the electrical system and our wiring. The spinal column, your brain's attached to the spinal cord. The spinal cord ends at L1, L2. There's 5 lumbar boxes. The spinal cord actually ends up here, and then it still continues to send these nerve roots that come down to our legs. So if any of this encroachment happens to be on a nerve, you can have extreme nerve pain or sciatica pain, which I don't wish on anybody, but people can talk to that. But it can also be from muscles and ligaments. It's not just discs, et cetera. But at any rate, if any of these holes where these electrical wiring is encroached upon, you can have a significant, oh my gosh, pain, right? And so a lot of times we do epidural injections. It's probably the most common procedure that we do here. And there's a lot of women, so I imagine some of you women have given birth to a future generation. And I imagine a portion of you potentially did it all natural, God bless you, or had an epidural. Good for you. If you had an epidural, this is basically what we're doing. In the obstetric population, we can't use x-ray because they got a baby in there and x-rays are bad for babies. So we just do it blindly, and we do that all the time and do it blindly. Again, the spinal cord ends up here. We actually do epidurals up here as well, but you have to be very careful because you don't want to do any sort of nerve damage to a spinal column or spinal cord. And there's techniques to make sure that you're safe. But at any rate, in the lumbar column, that's what this picture is. This is looking at the spine. This is a 2D image of a 3D representation. And a needle is delivered, and medication is deposited in the epidural space to decrease inflammation. If you have an acute radiculopathy, meaning an acute nerve injury, it just happened, it works better. The more chronic it is, it still works, but not as effective, which actually makes sense, right? If your back is a 150-year-old back compared to the 20-year-old back that was just bending over, picking up plants and had an acute disc rupture, that generally gets better on its own anyway. But if you can acutely calm that down, that patient, the 20-year-old, is going to have a much better architectural spine than the 150-year-old that's spine has been through 150 years of life, right? So that actually makes sense. But it's very effective. They typically are done in series of 3. And that in conjunction with medications gives people pretty good relief. Anybody heard of a facet joint? Facet joint or facet joint pain? So you have the jelly donut on top of the boxes, right? But then there's joints that are on the outside of the spine, and those are called the facet joints. And you can imagine there's two facet joints at each level. So you've got 7 cervical, 12 thoracic, 5 lumbar plus the sacrum. There's, do the math, a whole bunch of these facet joints that are kind of the golfer joints, I tell patients. So that what has me do this movement here, or what allows me to do that, is all my facet joints. I'm stressing all my facet joints by doing this. Those facet joints, just like knee joints, can get arthritic over time. And we can go in and actually deposit steroid in these facet joints, and if that works, we can go in and actually burn these nerves because they're pain nerves primarily. They don't have motor function of arms, but we can go in and burn them with that RFTC, radiofrequency thermocoagulation, fancy word, to burn nerves. So if it works, you can actually get a good component of relief with facet joint injections. Some patients come in and they have pain referred in this area, the shaded area here, and those can be from what we call facetogenic pain, or pain originating from the facet joints, or you can have cervical headaches, basically cervicogenic headaches, headache pain coming from the cervical spine that can be referred up to the cervical spine. So something to think about. There's primarily cervical and lumbar facets. You'll notice that your trunk doesn't have much of that golfer movement. It primarily comes from the back and the neck. But you notice from my trunk from here down, I don't really have movement, and that's by design. The facets are angled a little bit differently. So these are the kind of areas that we go in, a whole bunch of different nerves that we can target, and we can inject the joints. Again, if that works, you can actually burn nerves and give a component of pain relief. The lumbar facet referral pattern primarily in this dark area here. Everybody at some point has probably had pain that kind of refers in this low back area. The less dark it gets, the less common it is, but not completely uncommon to have a referral pattern from facet joints themselves. Large joint injections, we don't do just spine, we do large joint injections. And again, these injections are typically shoulder joints, hip joints, so they're not as common as the knee joints that we typically inject. So shoulders, hips, knees are kind of the big large joints that we go after. And also the sacroiliac joint is probably one of the more common joints that we do. Very simple procedure. Numb up the skin and subcutaneous tissues and then deposit anti-inflammatory medication right in those joints that give a really good component of relief. Steroid local anesthetic. I'm not going to talk about platelet-rich plasma or PRP, although it's another thing that you might hear about. Kobe Bryant and all these athletes going over somewhere and getting this PRP therapy. Something in the news. We actually don't have that ability yet, but we're working on it to get it here at UTMB. Visco supplementation. You might have heard patients getting rooster comb injections in their knees before. Again, it's basically a WD-40 tune-up into the knee, for lack of a better term. Yes, ma'am?
Where does cortisone fit in? Is it an anti-inflammatory?
Cortisone is considered a steroid. Yeah, and there's all different types of steroid concoctions, but cortisone is kind of the morphine of the opioids, right? So it's a steroid. So it'd be great to do steroid injections, each day, every day, but there's side effects with any procedure that we do that you have to be worried about. So typically 3 injections in a 12-month period, nobody would argue with. More than that, you have to be cautious about adrenal suppression issues, bone health, et cetera. You've heard of that Cushingnoid appearance or Cushing syndrome issues with steroids. You have to be cautious of that. This is just an SI joint. This is the pelvis. This is the lower back. And here's the sacroiliac joint. And this is just a needle depositing medication in the sacroiliac joint, which is a really common pain complaint that we get. And patients do great. And it takes 2 minutes. And it's a pretty helpful procedure. If that works, again, whether it's the cervical facets, lumbar facets, even thoracic facets, then you can burn nerves too, because you can burn pain-sensing nerves if they're primarily pain-sensing nerves and not motor nerves. RFTC is kind of what we call it, radiofrequency thermocoagulation, if you want to be real scientific about it. Introduced in the 50s, probably in the 70s, first used for chronic pain. And again, you're heating this little radiofrequency probe up to a certain temperature. Once you get above 45 degrees, it's considered a destructive lesion. And when you get to that point, you actually burn the nerves or creating a lesion around that pain nerve. Good for facets, which is where it's used primarily, but it's also now introduced to some knee applications, and this is kind of a newer thing that we've been doing, where you can actually burn nerves feeding the knee joint of itself. We're good. Okay. So this is kind of, again, another sexy intervention that's coming out that can help people. Osteoarthritis is a huge problem. Microdosing, again, it's the same thing as it's the hockey puck that we implanted for our pain patient a couple slides back, except you can do traditional therapy, which is that normal or higher dose opioid plus or minus other medications infusion in the spine, or the tradition or the kind of trend now, at least in this area, is to, if somebody's on chronic opioid therapy for chronic back pain, if they're a candidate, one of the algorithms that we do is we wean them off. And this is what I do even if you're on pain medications. Each year, I'm going to wean you off, and then you're going to have a holiday. And you're going to be on no pain medication for 4 to 6 weeks. And then we're going to start you either back on pain medication, or if this pump is a potential solution for it, we can consider pump implant. But anyway, you wean them, opioid wean, and then no opioids for a period of time. Then you give an intrathecal delivery of a very small fraction of medication, targeted delivery right to the spinal column, right at the source of where those opioid receptors work. And again, this is to combat tolerance, increase safety. There's something called opioid-induced hyperalgesia, which just means that paradoxically, the longer you're on opioids, you can have a paradoxic response to opioids themselves, and your pain can actually get worse. They do it with rats, where they have one rat and they get an opioid infusion. They have another rat. He's not on an opioid, and they introduce both rats to a real hot pan. And the rat that's on the opioids at first, he takes his time pulling his hand away. And the one that's not on opioids pulls his hand away right away. And then after a period of time, the rat that's on the pain medication infusion, he pulls his hand away quicker. And again, that's an opioid-induced hyperalgesia that we think happens in humans as well. But at any rate, microdosing is something that we can use to combat that. I'm just going to spend 2 minutes on this, or maybe 1 minute. Vertebral compression fractures. It's a common osteoporosis. 1 in 3 women over the age of 50 have it. Some people in this room might have heard or have osteoporosis themselves. And vertebral compression fractures, I'm saying women because it's more common in women, but men as well. I think it's about 1 in 8. But vertebral compression fractures are common. For osteoporotic reasons, in my world, it's more common from a cancer that goes to bone region. But at any rate, this is kind of a striking figure here. And again, this comes from Medtronic's website. But about 300,000 hip fractures a year, about 400,000 wrist fractures, about 500,000 osteoporotic spine fractures a year. So it's a big problem. And the problem with spine fractures is that, you know when your mom used to be 6 foot tall, and then mom was 5'10", and then mom was 5'6", right? It starts this downward gravitational decline, and that can lead to other mobility and functional issues. And so therefore, early diagnosis and treatment is important. Again, in my world, it's usually a cancer pain or a cancer problem. It's a inadvertently found compression fracture that could be something else. Multiple myeloma is one of the common ones we used to put cement in their backs to kind of prevent that accordion-like, or try and stop the accordion-like problem that comes in. But vertebroplasty, kyphoplasty, all it is, the only difference between the two, Like, the only difference between the two, one, you're creating a hole and you're depositing cement. The other, there is no hole and you just deposit cement. But at any rate, again, I'm not going to go through logistics of how the procedure is necessarily done. This is more for my residents when I do it. But a trocar is introduced and cement is injected along the compression fracture, and the compression fracture is fixed. Here's the last thing I want to talk about, because it's kind of the thing that's getting the most attention lately, but it's spinal cord stimulation. And so it's a non-pharmacologic electrical way to treat pain, specifically intractable pain in the trunk, limbs, back, or what we call failed back surgery syndrome, patients that have had a laminectomy before. And what it is, I think of it like this. If Houston is the brain and I-45 is the spinal column, only a certain amount of traffic can get to Houston at one time. And it just so turns out that the pain fibers are like slow driving Walmart semis. And it turns out that the proprioception or touch fibers are the fast driving cop cars and Corvettes. And if you flood the spinal column with all the cop cars and the Corvettes, and then you add some construction, the semis are never going to make it. And that's, in a nutshell, what in 1965 Melzack and Wall called the gate theory control of pain. And so briefly again, what you do is you put a spinal cord lead and you stimulate what we call the posterior columns, which is the fast driving proprioception and touch Corvettes. And if we flood the highway of information to Houston with that stimulation, we block the slow driving Walmart semis. And this process involves psychological evaluation. Again, that's for insurance purposes. And then there's a trial period, and it's the one procedure that you can try out first. And if you don't like it, you're back to square one. And you basically have an epidural, just like all the women laboring today are going to get without any x-ray guidance. But you get an epidural via x-ray guidance. You get a lead that's floated up into the spinal column. You can see here, as this lead gets floated up, and again, it's floated up typically in the thoracic area, then it stimulates the posterior columns, and then you try it out for a week, and you let us know how you feel. If you like it, if you don't like it, if it's covering all the areas that you hurt. You come back in a week and the leads are pulled out. If you want to go to implant and you convince the physician, i.e. me, that yes, this is life-changing, I want to have it done, then we go have it done. If not, if you're on the fence, then we don't do it. But if you go to implant, then you come to surgery, and sorry for the graphicness, but a little incision is made, and the leads are actually sutured down now, just like they were sort of for the intrathecal delivery. It's generally tunneled. This picture is showing it tunneled to the abdomen. It's tunneled to a little battery that's probably just smaller than my badge here, but that battery is usually put kind of in the button. It's a rechargeable battery. And then it's an internalized system that you can control the electricity delivered along your spinal column that can result in pain relief. And there's 3 different companies. Again, I don't have ties to any one of these companies, but each company has a little bit different technology that they promote. One of which, Medtronic, which is most that we do right now, me personally, they have MRI compatibility that the others don't, although that's going to change. And there's also some new technological advances that are coming that's going to change this whole algorithm. But you're going to hear more and more about this in the future. So anyway, that's like a quick, I hope everybody was flooded with a bunch of information. But pain is complex, right? Targeted drug delivery is what we try and do, or targeted delivery nerve injections or procedures are what we try and do, but it's often not just one target. And so you have to interventions are helpful, but you have to treat the whole patient. Pain is again complex. The guy that shot his foot, just if you remember that picture. Multimodal therapy, opioids and non-opioid adjuncts are very common. The non-opioid adjuncts compared to the opioids because of that problem that I introduced in the beginning. And you have to treat the entire patient. We were having a talk before. What percentage of patients do you think in chronic pain have some sort of psychological comorbidity, whether that's anxiety, depression, whatever? It's the vast majority. And if you didn't have it beforehand, you're going to have it, or you're very high risk to have it, right? You don't need to have pain to have anxiety, depression, or issues dealing with pain, but if you have pain, that's certainly a huge risk factor. So you need to address that portion, with pain as well. Just some image references, and then I'll leave it open for questions there. These are the clinicians in our group. That's me there in the middle. Dr. Williams, Dr. Baker, who's our pain psychologist, Dr. Cook, Dr. Dulatram, Dr. Ranganathan, Dr. Solanki, who's been around here forever. She's kind of like the godmother of the group. And Dr. Wilkes. This is the UTMB pain group. And then off to the bottom right are some of my colleagues that I still work with closely at the MD Anderson, the cancer pain world. Dr. Larry Driver here in the middle, he's been up there for years. Dr. Abdi's the chairman. Dr. Gephardt, Dr. Nuri, Dr. Diane Novi, again a pain psychologist, she's fantastic. Dr. Koy Lagunta, Dr. Mitchell, Dr. Burrell, and Dr. Chai. So all these people I work with a lot, and I've learned a lot from, and we still collaborate and kind of put our heads together. With that, I'm sorry, there's a lot of information. I hope it was helpful. If you guys have any questions, I'd be happy to entertain any questions. Yes, ma'am.
Okay, this wasn't really covered, but can you tell me what is the component in marijuana that they're using, for treating pain, and how does that work?
Yeah, so that was a question that brought up. So right now, currently, in the state of Texas, marijuana is illegal, meaning if you come into our pain, it's still considered an illicit substance at UTMB. If you come in, we do drug screenings, and if it's in your system, we can't prescribe any opioid controlled substances to you. So that is an issue. Obviously, it's state to state right now as far as what medical marijuana is. Medical marijuana is just marijuana. It's just got a medical tag to it. My personal feelings on marijuana is I think I want to wait and see where some of this research is going to go. I think in my clinic, anecdotally, I've seen a lot of the amotivational, destructive properties and gateway links of marijuana or medical marijuana, call it what you want, of marijuana in the younger crowd, which I think is potentially dangerous. I think it potentially has a role, specifically in seizure disorder stuff. There's some literature out there, but the CBD component of marijuana is the kind of active ingredient. However, all you have to do is pick up a paper and you read about spice and all this other stuff. They talk about the marijuana today is not the marijuana of mom and dad. Over at the Woodstock marijuana days, the marijuana now is potentially, it's not regulated by the FDA. It doesn't go through a lab. There's potentially contaminants, and there's potentially other stuff that's in there that's killing people too. The Spice 2K stuff. You read the Houston Chronicle. It talks about this stuff. So my position on marijuana for pain relief is there might be something there. At MD Anderson, Marinol, which has kind of which tests positive can test positive for marijuana, it uses kind of an appetite stimulant. For pain, it's not mainstream, and it's certainly not even allowed here in the state of Texas. So.
The component, that THC is that?
The THC is the one that's tested for. Yes, ma'am. Yes, ma'am. So that's the, and again. This is a whole other topic, I guess, for a different day. But I have reluctance with kind of in the media of how marijuana has suddenly been portrayed as almost the wonder drug that's going to fix everything. Use marijuana today, you'll get your no cancer, and your car's going to be paid for, and this is going to it's almost being sold as that, which it's not regulated. So I advise caution in interpreting some of that. Just like we have to advise caution on opioid, and non-opioid pain prescribing practices. But
What about these TENS unit type devices that we're seeing advertised so much? Are they effective?
So they can, and that is similar to sort of the spinal cord stimulation model, if you will. Spinal cord, when you were little and you stubbed your toe or hit your head and you go, dag nabbit, and you started rubbing, right? That's kind of spinal cord stimulation, right? You're trying to flood the brain with the Corvettes so that the semi-trucks don't get through, right? Because ouch, that really hurts, and it sort of works. TENS units, I explain it kind of that way. The problem with that, just like all medicine, getting approval with insurance companies to pay for devices can be problematic. But in my population, I certainly offer it, and I try and get it, and it can be very effective, specifically in the physical therapy.
Things that they're selling over the counter.
TENS unit?
Well, I don't know that it's a TENS unit per
There's
se.
TENS unit, electrical stim, all kinds of stuff. Again, some of that has to do with improving range of motion, improving vascularity, or bringing kind of blood to an area to promote healing, or that spinal cord stimulation model. Again, there's about 150 different devices that all sell and promote a different advantage or disadvantage. But I'm a big proponent of if it works, use it. As long as it doesn't have major side effects. And I think I've not heard a single case report of somebody dying from a TENS unit. or having a problems with TENS unit, and I have a lot of patients that it helps. So that's the first question is, how long is this going to last? That's typically what we get. And the answer to that is we don't know. If you're the 20-year-old compared to the 150-year-old, the 20-year-old has studies statistically they're going to have a potential better outcome, and that just makes sense because you're 20 as opposed to being 150 and all the architectural changes that have happened. As far as if you can avoid surgery, a lot of good surgeons that I know, if you go to a shoe salesman, you're going to get a pair of shoes, right? If you go to a surgeon, you're going to get a surgery. If you go to a surgeon that says, I'm not going to operate on you, you've gone to a good surgeon. And if you've gone to a surgeon that says, I'm not going to operate until this, or this happens, and I really think it's going to be effective for you, then you've gone to a really good surgeon that has explained the risks and benefits. There's no risk-free surgery. There's no risk-free procedure, interventional, anything. So if you can use injection therapy, 90% of back pain goes away with time. 90% of people in this room have back pain, but 90% goes away with time, typically. Injections can help bridge that. If you have a motor deficit, loss of bowel or bladder issues, that's surgical emergency, needs to be surgically corrected. So like acute onset, I can't suddenly move my leg when yesterday or 5 minutes ago I couldn't move my leg. That needs to be surgically decompressed. That wouldn't be an indication for injection therapy. But to do surgery to fix pain, I've got a lot of patients that have done surgery to fix pain that potentially got better, but then got worse later. And that's spinal cord stimulation. There's some studies that have shown that actually spinal cord stimulation versus reoperation for back issues outside the context of nerve deficits, that spinal cord stimulation was superior. So you want to think twice before you want to really cross your T's and dot your I's before you decide to have somebody cut on you.
Okay.
The trend now,
Yes.
compared to 10 years ago, maybe even 5 years ago, is less and less steroid, and it's thought now that it's not even the steroid that's necessarily it's one of the components that's working, but it's actually flushing out some of the inflammatory mediators with local anesthetic and saline, so that proportion of the special concoction that's injected, it's becoming more and more, it's some steroid, but more and more of the local anesthetic and non-steroid stuff to prevent the side effects. But yes, it's not uncommon for your sugar to go up if you're a diabetic, even if you're not a diabetic, and not uncommon to potentially have some of those either rashes or unpleasant feelings for a day or two after the procedure. Yes.
UTMB Health, working together to work wonders.